Thank you so much for the kind introduction, and I hope you can hear me.
Very honored to be a part of the SSBMT annual meeting, again virtually, but hopefully next time we meet in person. And I'm also delighted to talk about steroid-refractory chronic GVHD, because actually this field is becoming interesting nowadays with the new drugs emerging in the field. This is going to be the roadmap of my talk. I will try to start with definitions and endpoint clinical trials, move on to clinical trials and recent approvals of the drugs in the setting, but also not to forget ancillary and supportive care, and end with the new NIH consensus and the perspectives that it gives in the field. So starting from definitions, I think we are all very well aware that even this is hard in steroid-refractory chronic GVHD, and that we haven't had good definitions for a long time. Several years ago, though, NIH, EBMT, and CIBMTR have joined forces and tried to provide us with a consensus on the definitions of steroid-refractory GVHD. And this is the paper that was produced in 2018 and defines steroid-refractory GVHD, the one which is progression on steroids for 1 to 2 weeks, or stable GVHD for 1 to 2 months. While steroid dependence is typically referred as inability to control GVHD symptoms on tapering in at least 2 individual attempts separated by at least 8 weeks. However, I think it's very also important to acknowledge that many of the patients have to stop first-line treatment because they're steroid intolerant. Of course, we are all very well aware of many of the toxicities of steroids. Among of them, many are unacceptable, and therefore patients will need also the second line. Actually, less than 20% of patients with chronic GVHD achieve durable, partial, or complete responses and survive 1 year after initial therapy without additional systemic one. And therefore, steroid-refractory GVHD is really an unmet clinical need. We know that staging, diagnosis, staging, response, that all has not been very well established in the past, but thanks to the NIH initiatives, thanks to the NIH consensus in 2014, we really got this cleared. And also what we have had in the meantime to pave the way for clinical trials is, besides having short-term endpoints as overall response ratio, which we can get from phase 1 to 2 trials, and we are sometimes not able to wait long-term survival and time to off immunosuppression as a result of phase 3 trials. We have more recently, or maybe in the last 10 years, have started to evaluate an intermediate outcome, which is failure-free survival, which along with the taper of steroids is really an adequate outcome measure from phase 2 trials, which really helps us move on with clinical trials and approval of drugs. Failure-free survival has been shown that it can serve as a meaningful endpoint for clinical trials. In this study from 10 years ago, where actually failure-free survival, as we know, is survival without relapse and without the need of the change of therapy or that additional immunosuppression. And in this study, it has been shown that failure-free survival after second-line treatment is 56% at 6 months, 45% at 12, 1 at 24, and only 25% at 48 months. And that withdrawal of immunosuppression happens in only 15% of patients at 48 months, really, again, underlining the need for new drugs in the field and highlighting steroid-refractory chronic GVHD as an unmet clinical need. This after the NIH initiative and the FFS really, let's say, advanced clinical trials. And I think how desperate was this field shows the fact that really soon after, actually in 2017, we got the first drug and approved by the FDA, and surprisingly after a phase 1b/2 study. We all know that ibrutinib in this study was evaluated in patients who failed 1 to 3 previous therapies, and this study gave us, but mostly in skin GVHD patient, gave us an overall response of 67%, but had only median follow-up of 14 months. However, this was enough for its approval. Later on, we've seen with a longer follow-up of 26 months that the overall response is sustained, and also that FFS at 18 months is 51%, which compares favorably to historic benchmarks of 35%. Also, 2/3 of patients reached acceptable lower level of steroids, and meaning that both beside short-term outcomes, the mid-term outcomes were also satisfying. However, when it comes to toxicities of ibrutinib, we know that these are significant, although grade 3 to 4 adverse events are mostly fatigue, diarrhea, infections, and pneumonia. I think that we have to acknowledge that discontinuation rate to side effects is 43%, and it might be even more in the real-life setting, because when we conducted in the EBMT a survey on the management of steroid-refractory GVHD by the Transplant Complications Working Party, and we have done that in 2021 before of the approval of new drugs. Although mostly European centers, we had a huge population of 105 centers in 33 countries. And here we have found that the practice for the second line is really heterogeneous, with most centers actually using more than 2 agents, so not having a standard second line, although 65% of centers do have a standard operating procedure. Actually, the most used agents in the survey or in the centers, but found in the survey, were ruxolitinib and ECP. With, as you can see, a huge list of different agents used, and ibrutinib falling only on the 6th position in 90%, used in 90% of the centers. Of course, many of the centers include patients in clinical trials, but what is also, I think, important to highlight here, and I will mention it again later, then only a third of centers treat patients through a GVHD team or through a multidisciplinary approach, which I think is crucial in chronic GVHD. However, later on that year, and of course, the use of ruxolitinib was mainly done by the data that we had from retrospective trials. But very soon later, in 2021, after this survey, we got the results of the REACH3 trial, which we all know compared ruxolitinib to best available therapy, a list of 10 common choices, where most common were ECP, MMF, and ibrutinib in patients with moderate severe GVHD. And we know that this study showed that overall response of ruxolitinib was significantly better than best available therapy, which was the primary endpoint, and secondary endpoint were achieved, as well as higher symptom response and better failure-free survival of 18 towards 5.7 months, or 75 towards 45% at 6 months. And also decrease in steroids, so again a mid-term outcome, was slightly higher in the Rux arm, although the paper didn't show the real numbers of that. 69% also had a maintained response at 1 year, and all this led to approval by FDA in September of that year, and a bit later by EMA. But here, most of the patients actually had one previous line of treatment, and it was approved in patients who had inadequate response to steroids or other treatments. So really approved as the real second line. When it comes to toxicities, grade 3 infections, what is of course always important in those patients treated with several lines, were similar in the two groups in comparison to best available therapy. However, 16% of patients on the Ruxo arm discontinued treatment, which seemed higher than the best available therapy. And we know that that's mostly because of the grade 3 toxicities and which are cytopenias in ruxolitinib, which we of course face every day. When it comes to highlights from the EBMT, I think this year's EBMT was more focused on acute GVHD, but as opposed to the previous one where we had lots of these data on chronic GVHD. But we did see something interesting that I think is a highlight, and that's orally presented data on crossover to ruxolitinib from the same study, which showed that ruxolitinib has high efficacy and manageable toxicity even after the best available therapy. So let's say after as the third line in patients after week 24 when the primary endpoint was evaluated. So if progression, flare, stable disease or toxicity in 1/3 of patients that happened actually. And we can see here that patients, and 69 of them changed best available therapy to ruxolitinib, showed actually comparable overall responses to the middle column, and that's the ruxolitinib arm, so 48 to 49%. And also the rate of serious adverse events was similar. Also, interestingly, only 7% discontinued treatment in this arm in comparison to the Rux, which was 16%, as I mentioned earlier. This moves me to the third line and the trials that we have on belumosudil. Belumosudil is, as we know, and that's the trial is called the Rockstar trial, because the drug is the ROCK2 inhibitor, which does two things. One is shifting Th17 to Tregs, and the other one, which is really important, is the antifibrotic action, and reduces fibrosis actually by downregulating the TGF-beta signaling and profibrotic gene expression, which is really important because we know that once fibrosis happens, chronic GVHD becomes irreversible. Belumosudil was evaluated, we know, in two trials, phase 2A study in 54 patients, and then later on the right, a phase 2 study in 132 patients. Two dosages were tried and worked similarly, so 200 milligrams per day is the dosage that is then recommended. And overall responses were more than 75%, and as shown here on the right, it worked in all subgroups. So in patients who received ibrutinib before, ruxolitinib before, who had more than 4 lines of previous therapy, who were diagnosed with chronic GVHD before a long time, so meaning that it really worked in all these subgroups. When it comes to responses across organs, it also worked across all organs with really impressive data in joints and fascia, which we know is a huge problem. And the median time to response was 5 weeks, with most of the responses happening in the first 6 months. And all this was enough to approve belumosudil by the FDA as in steroid-refractory GVHD, actually after failure of at least 2 prior lines of systemic therapy in July of 2021, or as the third line. When later on we saw the except of these short-term outcomes, the intermediate outcomes, and that was done by a pooled analysis of these two trials, we saw that FFS was 75% at 6, 54 at 12, and 38% at 24 months, in comparison to historic rates of FFS of 56, 45, and 31%. Of course, it is considerably better. When it comes to risk factors which are associated with treatment failure with belumosudil, this study also showed that these are the progressive chronic GVHD, steroid-free upfront, and more than 2 prior lines of therapy. Also, 2/3 of patients were able to reduce steroid dose. Side toxicity was acceptable. Serious adverse events happened in around 30% of patients, with most frequently described side effects being fatigue, diarrhea, nausea, and cough. Well, this actually brings us from no drugs in the steroid-refractory chronic GVHD to having 3 after the last couple of years. And of course, this always brings us to the new question, which drug then to choose if we have all available, and once we hopefully will have them. Of course, when we face-to-face comparison are not very realistic, but when we compare the results of these studies, we can see that efficacy and toxicity is similar between those 3 drugs, between overall response rates, so short-term outcomes, FFS, mean steroid, this is similar. Also, serious adverse events with a bit more in the ibrutinib trial, but it means that if we have similar drugs, it becomes, of course, harder to choose. But in these terms, we will have to, in the future, try to see which drugs works better in which organ, and of course, choose by the affection of organs in our specific chronic GVHD patient. Of course, that means individualization of treatment. And also, since most of the responses that today we have are partial remissions, we will also have to think of combinations. But when thinking of combinations, we have to have in mind biology of the disease. We have also learned a lot in the biology of chronic GVHD. Luckily, we know that most of the targets so far have been in the phase 2 in blocking the priming of T and B cells. This is how ibrutinib and ROCK2 inhibition works as well. But the focus today is really moving to phase 3 and the drugs that have the antifibrotic effect as well, because we know that phase 3 is driven by macrophages, which then induce fibroblasts, which then decompose extracellular matrix, which leads to sclerosis. I have to also, we have drugs now, but I also have to mention, and I would really like to highlight how important is ancillary and supportive care, because I think in steroid refractory and chronic GVHD in general is really, really something irreplaceable and has to be at least as important as drugs. And here I think we should follow several postulates. First of all, we have to have in mind also the natural course of chronic GVHD, and although this is an autoimmune disease, it is not an autoimmune disease for life, because immunological tolerance does emerge. We don't want to miss that moment, and therefore chronic GVHD should be evaluated regularly every 3 to 6 months, even if we are not changing the drug or nothing is changing the symptoms. But intensity of treatment should be calibrated periodically by lowering immunosuppression to allow chronic GVHD to emerge before increasing the dose. Also, we have to have in mind that most patients die from infections, and this study here on the left shows that patients who have immunosuppression at 1 year after transplant actually die more, which is very important, and therefore everything listed on the right, antibiotics, antivirals, antifungals, vaccination, is very important. We have to have in mind in these patients, and also we have to have in mind to treat them with at least systemic immunosuppression as possible. This is sometimes possible with adding ancillary treatment with local therapies. How important this is highlighted by the whole in one of the NIH document. The whole one is dedicated to ancillary and supportive care. Luckily, this local treatments are developed well and work best in oral skin and eye GVHD, which are the most frequent manifestations as well. And considering aggressive local therapy can actually, or increasing local therapies can actually help us decrease the systemic immunosuppression treatment, which is the goal. And also what I've mentioned before, and I think it's really, really important, is that ideally patients should be managed not only by a BMT physician, because it's really hard to treat a multisystemic disorder like chronic GVHD by only one specialist, but ideally chronic GVHD patients should be through a dedicated GVHD multidisciplinary team with different specialists involved, and that this really works has been shown before, but this is an interesting small study which showed that patients involved in this way of management and evaluated before and after 1 year of the management through multidisciplinary approach actually have significant improvements in quality of life, which is of course our ultimate goal. What about the perspectives? Finally, well, after paving the way for new drugs, by the second NIH consensus, the third one held in 2020 is now shifting focus to prevention of steroid-refractory GVHD by working on identifying risk factors for highly morbid forms on early diagnosis, maybe with biomarkers, which we know that we don't have so far in this setting. Also preemptive treatment in high-risk patients, and focus maybe moving those agents that work in the second line to first line and moving towards steroid-free approach. Also, better management of highly morbid form is especially crucial. And as I said here, the focus is really moving to antifibrotic drugs. One of the more recent drugs that is becoming interesting is axatilimab, which has been evaluated in phase 1 to 2 study, which is interesting because it actually interferes with macrophage-driven fibrosis, and this is very, very recent data just published. This drug was evaluated in 40 patients, phase 1 and 2 study, and in patients who were pre-treated, who got ibrutinib, ruxolitinib, belomucil before, who had median prior lines of 4 and median 4 organs involved. And here they reached the primary point with the overall response of 50% at day 1 of cycle 7, but in all overall responses after 6 cycles were even 82%, and importantly a very nice improvement of quality of life of 58% and responses across all organs. When it comes to identifying new highly morbid forms, also we might not be able to use biomarkers still, but maybe some of the new diagnostic tools are becoming interesting. And I like to mention this study always because it's an extremely interesting approach, and that's artificial intelligence involved in chronic GVHD, where this was published in Hematology, and patients evaluated according to the NIH consensus criteria were actually analyzed by a computational approach, and 7 different phenotypes that we haven't recognized so far have been recognized here, which could be stratified into risk groups, which then stratified survival very well, as you can see here on the left. And this could also be very easily reproduced in the clinical setting by a simple decision tree, which you can see here on the right. Finally, when it comes to highly morbid forms, we are moving, and this is the perspective, I hope, for the future as well. We have some of the new data in belomucil, INDBOS, where this is the more recent data on 59 patients from the earlier mentioned study, where the overall response rate was 39%, and it worked, of course, better in patients with the lower baseline NIH lung score. Also, and this is really the most recently, the already mentioned axatilimab also has been analyzed, only preliminarily low numbers, 32 patients, but it seemed in these 32 patients, BOS was present in 15 patients with median of 5 previous treatments. And in these 15 patients, actually 8 patients had a partial remission and 5 of them had symptoms improvement, which is, I think, really respectable data, and acceptable toxicity was seen as well. So I think with this, I will stop, and thank you for listening. And also, I will be very happy to take any questions.